Hello, my name is Hope Frost and I am delighted on behalf of SBK Healthcare to welcome you to this Embedding APS in Clinical Practice in Scotland video recording. If you would like to find out more about our online live events and our face-to-face upcoming courses, please do visit our Diabetes National Networking Forum website. Please do share your feedback for this recording in the comments section and make sure that you like and subscribe so that you don't miss any new content that we upload. So it is now my pleasure to introduce you to your online conference chair and your opening speaker, Professor Brian Kennon, the National Lead for Diabetes. Over to you, Brian.
Hi there, thanks Hope. So there's a lot of well-kent faces in the audience, so good afternoon everybody and thanks for giving up your lunch. I think we'd all agree that this is a very important area that we probably all need upskilled in, so thanks to Advanced Therapeutics and SBK Healthcare for leading in this and also CamDiab for their contributions. So first of all, my name is Brian Kennon. I'm one of the diabetes consultants in Glasgow and for my sins National Lead for Diabetes. I'm just going to invite the speakers for this afternoon's session to just turn on their cameras and wave hello. So we've got Nick and Karen from Advanced Therapeutics, thank you. And Candice is also joining us from CamDiab. And I was really just going to start with a bit of a basic introduction. So I'm just going to share my slides in a wee second. So if I could ask the speakers to turn their cameras off again, then that would be great. Just to re-emphasize, as Hope has already said, if I could encourage you to use the chat box, then that would be brilliant, particularly for any questions that you might have. And timings are tight, so if we don't get time at the end of each presentation to go over the questions, then the speaker should still be able to respond to the chat box. So I encourage you to use the chat box. And we're going to try a wee bit of interactive audience participation here. So I don't know if any of you have used Slido before, but if you've got your mobile on you, you can just hold it up to the screen and get your QR code, and it will take you immediately to this question. And we're just keen to try and capture some feedback from healthcare professionals involved in this space as to what you perceive the biggest challenge to embedding closed loop systems and APS within your system. And then if some of you are willing to play and join in, then we should start to see a word cloud forming. So I'm going to give you a minute to try and find your mobiles, to turn on the camera function, look at the QR code. So we've got one reply, thank you, funding has come in. Staffing, money. I should have really changed that and said, what do you perceive the biggest challenge to delivering healthcare in anywhere in the UK or indeed the world is just now? And I'm sure we would come under staffing and funding, but yeah, okay. So that's brilliant. Thanks for all the responses. So the bigger the word, the more people have responded, highlighting that as an issue. Okay, so staff experience, knowledge, staff funding, staffing, training, education resources, training for PEDS, logistics. Okay, well, that's really useful. Feel free to keep that coming, but hopefully we'll be able to cover at least some of that within the content of our next hour and a half for the presentations. I should just highlight as well that I had been in touch with clinical leads for each of the board areas, and we're going to go into a breakout meeting at 2 o'clock to maybe discuss some of the logistics which have been flagged up. I'm sure as many, if not all of you will be aware, then we have had improving access to diabetes technologies as a priority within the Scottish Government's Diabetes Improvement Plan, really since 2014, and it was re-emphasised by the refresh of the plan last year. Obviously, in that 7 or 8 years since we made the policy commitment to improving access to technology, then the technology's moved on afoot, and we've gone from low glucose suspend to predictive low glucose suspend to now more at section 3, the sort of hybrid closed loops. And now we're on the brink of the fully automated closed loops, albeit that the dual hormones are still a wee bit away yet. We have been working away in the background for those 7 or 8 years to try and ensure that the issues that have been highlighted in Slido, such as funding and things, don't become barriers, or at least if it is a barrier, then we try and mitigate it as best we can. So we have been having discussions with the National Planning Board to take long-term strategic decisions for NHS Scotland, to try and ensure that artificial pancreas systems and closed-loop systems are on the agenda. And it was from those discussions that the Scottish Health Technologies Group were commissioned to do the work around closed loops that I'm just about to talk about. So I'm sure many, if not all of you, will have been cited on the guidance that came out from January of this year. And this was a specific recommendation around closed loop systems. And it highlighted that just now, the only commercially available system is obviously single hormone, which is insulin, and that the dual hormone systems are unlikely to be available, well, now or within the next year or so. But there is a really powerful message in here, and I think it touches on what a lot of us feel as clinicians, but also within policy, and is that we need to make sure that we don't widen inequalities with our access to diabetes technologies. So there is a recommendation that we as a clinical community should be proactively making sure that the discussions we have about access to closed loops and other technologies are with all people with type 1 diabetes, and to try and minimize disadvantage. And these are the recommendations, which, as I say, I'm sure many of you have already seen, but it's recommended that we should consider closed loop systems and those individuals whose current diabetes care plan, they either have suboptimal glycemic control, ongoing issues with severe hypoglycemia, or indeed this underpinning of significant diabetes distress. And I think the latter recommendation came from a lot of the person with diabetes feedback, that we shouldn't be penalising people who work very hard every day to manage their diabetes, albeit at a significant level of distress from accessing these technologies. I think in Scotland, most of the hypoglycemia issues we've already addressed with our current funding and pump and CGM provision, but it is an important group that we need to keep trying to target. And another thing for us as healthcare teams that was emphasised as part of the recommendation is really the plea, because it is a plea, that we do ensure that all of this information is captured within Sky Diabetes, because we're keen to use the information within Sky Diabetes to drive health improvement, to do real world evaluations of these technologies, and to try and get better insights as to who may or may not benefit from these technologies. I think most of us who are involved in this space will be aware that a lot of the evidence base to date is already in people who do quite well with their diabetes, who are already reasonably well controlled, and these technologies help them manage their diabetes even better. And I think we need to try and get real world evidence for cohorts of patients who possibly don't reach the clinical trials that are out there to date. And that's the benefit we have in NHS Scotland with Sky Diabetes. So a plea that we make sure that we're getting robust capturing of the systems that we're using and the cohorts we're using them in. So again, I'm sure many of you are aware, but we managed to put in a successful bid to get capital investment for a further £14.6 million. I feel that I should apologise, because I appreciate the end of year's capital investment isn't the best way overall to strategically support access to diabetes technologies. But when it's the only opportunity that's presented to us, then I think we've made no apology for trying to utilise that. And the key areas that we've targeted for that investment are around replacement pumps, so that when a quarter of the pump population are out of warranty, we're replacing them with pumps that are potentially loopable. That we do try and improve access to CGM, and that's a main focus of this funding around the health technologies guidance that I've already mentioned. That there's ongoing support for CGM provision in pregnancy, but I think we'd also be keen to ensure that if individuals are on MDI where CGM might be applicable, or indeed improved access to pumps, then funding can be used to support that. And in all honesty, there are several board areas who have used the funding, particularly the funding that would have been ring fence for replacement pumps, to make a case for additional resource and staffing to help support this provision of these technologies. I mean, I do want to make a special thanks to Kenny Rees from NHS Procurement, who's spent an inordinate amount of time driving these discussions with industry partners and indeed getting excellent deals for NHS Scotland and indeed taxpayers. And also a massive thanks to the MCNs and indeed individuals at the boards who've had to take this on, because I don't underestimate the challenge. But really sort of pertinent today is the fact that we got £1.2 million ring-fenced to support 200 individuals to start on the DANA CamAPS Dexcom system, and that'll be the focus of today's discussion. So I think there are a few considerations. One is around upskilling staff, and hopefully this session helps allow to do that. We have identified clinical leads. We do need to consider what the logistical issues are, and I've highlighted that we are keen to do real-world evaluation using Sky Diabetes. And at the meeting at 2 o'clock today, I would like to think about who the specific cohorts who might benefit. And as I've already said, acknowledge that realising this opportunity won't be easy, but at least we're having a discussion about the opportunity that we've got a chance to realise than not having any opportunity at all. So I'm going to finish there by means of an introduction and stop sharing my screen.
Hi, everybody. So my name's Nick, and I'm a territory manager for Advanced Therapeutics UK. I'm going to be talking to you today about the DANA eye pump, just an introduction to it and the capabilities of the system, why you might choose the DANA pump, and you'll get to see the various platforms that it offers patients. So without further ado.
Nick, I just want to tell you that I'm sharing your slides for you.
Oh, are you?
Are you planning to share them?
No, if you want to share them, that's absolutely fine.
Can you say next when you want me to change?
I will, yes. So you can see, for those of you who don't have my email address, I decided to put it on the opening slide just in case you want to make a note of that, and if you need to ask me anything. As well as being a territory manager, I'm also your sort of main point of contact for Scotland, and we'll be supporting you with the training for yourselves and for the patients for pump starts, that kind of thing. So next, Sarah, thank you. Okay, many of you probably don't know this, but Suil, which are the manufacturer of the DANA pumps, have actually been doing this for quite some time and have a strong heritage in pump therapy. It was something I wasn't actually aware of at all, and you can see this dates back as far as 1979, and then 1980 when the first sort of commercialized insulin pump was available, and since then you can see they've produced a number of different systems that have been relevant to the needs of the market and the capabilities of the technology at the time, into the 80s, 90s, noughties. And then I think what was particularly significant in between 2015 and 2018 was the introduction of the AnyDANA apps, which were for both the Android smartphones and the Apple iOS smartphones, and the DANA RS pump. And the reason this is so significant is because of the interoperability that this pump offered, because it could be used in harmony with an app that would completely control pretty much everything you need to control on the pump, and therefore negate the need for the user to actually get the pump out at all, other than to actually just change infusion set and the cartridge. Everything else could be operated via the app itself, and so it made things very discreet and very slick for the patient. And this has been further improved with the introduction here of the DANA eye pump, where we've tweaked the DANA RS a little bit further. We've improved the screen. There's a few other things like the battery. We introduced the alkaline AAA battery to this pump as well, but it still has the interoperability that the DANA RS had, so it can be used with the AnyDANA app as well, and it also offers 24-hourly segments, which the RS couldn't do at the time. Next slide, Sarah, thank you. So why would people choose a DANA pump? you know, I understand that a lot of the people in this audience today have not seen a Dana pump or even heard of Dana pumps before. So if you think about, could you just click on the button there, Sarah? Yeah, so it might be to control the pump from the phone. Now, the Dana pumps, we're actually the only provider that offers this capability from a smartphone at present, whereby, as I said previously, everything can be operated from the smartphone. So that's something that offers just, you know, flexibility and discretion for patients, but also to be used as part of an artificial pancreas system. And we already have, for example, a number of patients that are using things like Android APS in Scotland and getting tremendous success. But now, of course, we also have that link with CamDiab and the CamAPS FX system, which of course is a commercialized and licensed system. Next slide, Sarah. And just click the button again, please. Thank you. Yeah, so what's important? Well, the interoperability is particularly key, isn't it, with this Dana pump, because being able to work in harmony with other systems and share information with each other offers patients that discretion that we talked about, whereby they keep the pump in their pocket or their pump pouch, never need to get it out. So patients need not feel conscious about doing that. They can just operate everything from their smartphone, and it could be on any app when they're doing that. So that's quite nice to know. Offers that flexibility, and patients are starting to see better control, better outcomes by using the Dana pump with these APS systems. Just click again, please. And one of the things that we offer besides the hybrid closed loop, and it's really important to know this because not everybody's going to go onto a hybrid closed loop, but we also, this Any Dana app that I mentioned at the beginning of the presentation, which can be, as I said, used on both Android and iPhone smartphone systems. You know, this is a free app, and again, as I say, it just makes it possible for people to operate everything on the pump from that app. And if you think about patients, for example, who may be, I don't know, looking to have children in a year or two's time, but are due an upgrade on their pump, this might be a really good option, just because the transition to CamAPS, when they finally do decide to do that, would be extremely seamless. They simply delete the app and then go to CamAPS. Just click again, Sarah, thanks. And then you have the CamAPS, which, for those of you that don't know about CamAPS yet, is licensed from 1 year upwards, and specifically in pregnancy because of the amount of data and trial data that's there in pregnancy. And there's some fantastic results with that. And that's particularly important, I think, because of the tight control that the system can offer. Next slide. Moving on to the Dana features, I'm just going to go down to the second from bottom there, because I think this is also really important to point out, is that besides being used with the Any Dana app and CamAPS app, the Dana iPump can be used as a standalone system. The reason this can be facilitated is because of the fact it has a built-in bolus calculator. And again, some patients who aren't so techie, they actually quite like this about pumps. You know, they just want to operate them as a standalone pump. It also provides a backup system in case, say, somebody had forgotten their phone, or they'd lost their phone, had it stolen or damaged. So that's quite nice to know that you've got that backup feature with a standalone system. The thing about the Dana pump, because it can be used as an interoperable system, it means it's also future-proof, because it could be used with other systems that might be launched later down the line. It might be interesting to note that the firmware on the system can be updated. So again, any improvements that might come with the Dana iPump, these can be updated whilst within the warranty for the patient. They're not having to wait for the next pump. The pump itself offers very small basal increments, as you can see. It will deliver a 0 basal rate. The first deliverable amount is 0.04, but can be changed by 0.01 upwards. Bolus increments 0.05, and this goes very well with the CamAPS. The pump Again, 83 grams, does that mean it much to anybody? Well, that actually makes it probably the, if not equal to, the lightest pump available commercially on the market. So that's quite nice again for patients, particularly the smaller patients who want something small, discreet, and not heavy to wear. The insulin reservoir offers a lot of flexibility because it holds as much as 300 units. But again, for those on much smaller requirements, you can part fill that reservoir with as little as 50 units. And for the use of the AnyDana app and CamAPS, it operates on a low energy Bluetooth, which is 5.0. Next slide. Again, I think what's really good, besides the flexibility of the different platforms that the Dana pump offers, we've also got 4 different cannula types for the Dana pump. We have the Dana Inset 2, which for those of you who look at the illustration on the right-hand side, you'll probably recognize this. So it offers quite a nice low-profile cannula connection to the skin, but also has a built-in inserter device for them to carry around. Both the soft release O and the soft release micro at the bottom, these can be characterized quite simply by the blue tubing, and they offer a 360 rotating head, so that's quite nice for a lot of people as well. And then we have this other one that we call the easy release, which is purely a steel cannula system, but again, an extremely low profile cannula, and some people prefer this, and you'll notice that the shortest cannula there is probably the shortest available in the market at present of 4.5 millimeters. Next slide.
That's your 5-minute warning, Nick.
Thank you. Thank you. And just on to the training support. So this is what we offer from Advanced Therapeutics to support both patients and healthcare professionals with the Dana eye pump. We have a number of online training videos which some of you may already have seen on YouTube, and we readily send this out normally prior to pump starts. So it's an opportunity for both patients or parents, carers, to familiarize themselves with the pump, how to operate it, how to change sets, how to program it before they even come to the pump start. And this seems to really make a big difference to people. So, so we have that for both for patients and for healthcare professionals. We offer face-to-face pump starts as well as virtual ones, and this has been very successful for what I'm gathering. I only joined the company back in December, so I'm a bit newer to it with regard to doing virtual stuff, but yeah, I've had to learn fast. We do offer 24-hour support for technical queries. This is 7 days a week. And you might be pleased to know that we offer a DPD for all patients who are receiving delivery of their consumables for the Dana eye pump. And we offer accredited refresher training on the Dana eye, no longer Dana RS, as you can see on that slide. And we will support patient education and training where we can and where budgets allow. We are trying to offer as many demo pumps to centers as possible. Yeah, patients, pleased with that. We are doing our best to try and support you with that. And yeah, so next slide. Okay, so this is just to give everybody a little bit of a flavor, an overview of the CamAPS system and its components that make it up. So you can see right in the middle there, we have our smartphone, which at present is the Android phones only. And we do recommend, when it comes to sort of smartphone choice, to refer to the Dexcom G6 recommended list of approved phones for that. On the left, we've got the Dexcom G6 sensor, which of course is relaying the interstitial glucose back to the system. And then to the right-hand side, of course, we have the Dana pump. And all the while, you can also be feeding back this information to Diasend automatically, which usually updates every 5 to 10 minutes, provided that the phone has got a sort of 4G signal or Wi-Fi connection. So that's a nice overview of it. And on to the next slide. You have basically the patient wearing the system there. So you've got your sensor on the skin as well as the connection to the pump. and then the regulatory algorithm, which is built into the CamAPS on the smartphone. So again, remember, they're just carrying one device around with them, not carrying two sort of controlling devices as they might do with other systems. So hopefully that's been a bit of a useful flavor about that. Just to finish off, we've got a little bit of feedback which was shared very kindly with us by a patient in Burnley by the name of Rachel. Rachel's 32 years of age, and as you can see, she'd been type 1 for 12 years and previously been on multiple daily injections pre-pregnancy, with an initial sort of A1C of 67 millimoles per mole at the time. And she went on to CamAPS, and these are just some of the comments that she'd fed back following her experience with CamAPS. You know, things like, "This has revolutionized my life, and this is the closest that I've felt to having a cure or leading as normal life as possible." I think this is really quite some powerful words here. Especially, I think the third comment there, "More than anything, it relieves the mental load of managing diabetes, and I would recommend it to everyone." Yeah, and hopefully this is something that might be available at some point. As you can see, pre sort of CamAPS, she's 67 millimoles per mole, and after only 6 weeks of being on CamAPS, she's achieved a result of 42 millimoles per mole, and I think that's pretty damn impressive. I don't know what anyone else thinks, but yeah. So she's been a testament to the success of CamAPS with the Dana Eye insulin pump. So thank you very much, everybody, for that. And I will hand over now to Brian, who will then probably introduce our next speaker.
Thanks, Brian. Hi, and thank you for asking me to speak. I have the next 15 minutes to cover a really huge topic around the evidence behind CamAPS. So I'm going to spring on, but just as a quick word, my role in CamDiab is your training and outreach manager. So I will be supporting you as part of your clinical team, sort of really give that confidence and upskilling to the team, but I can also help support around patients and picking my brain, as many other centres in the UK do. So I will be your point of contact. As Nick has eloquently described the system, I am going to focus solely on the CamAPS evidence around its functionality as a closed loop algorithm for the next few minutes. But before we talk specifically about CamAPS, I want to take a step back into thinking about, why do we need closed loop when we've got sense augmented pump therapy? So if we look at diabetes registers, the DPV is from Germany and the type 1 diabetes exchanges in America, you can see that over the years, looking at different treatments, we are still not able to get the HbA1cs that we're trying to get with technology, even though we're getting more and more advanced in the types of technology we're offering. We can also see in the next slide that I've got there on the right, that actually, despite the years going by and improvements in technology, we're actually not achieving across the population group, and especially around young children and adults as well. Older adults, we're getting a lot of change in not achieving our HbA1cs. They're a lot higher despite using the better technology over the years. So, sorry. Whoops, I want to go back. So HbA1cs are not being achieved with current technology. The management burden from healthcare professionals as well as individuals using the system is very high, and there's a lot of negative impact on quality of life around managing type 1 diabetes. So we need newer technologies. CamAPS has been on a long journey. We started in the early 2000s doing clinical trials, and over the years we've done more and more research, not only to ensure the system is effective and safe, achieving the clinical outcomes we are wanting to achieve, but also making sure we're not impacting on quality in life. We want to improve quality of life. So over the last 15 years, with our high quality RCT data from very young children all the way through age groups, we have been able to robustly demonstrate reduced HbA1c, improved time in range, with reduced levels of hypoglycemia and improved quality of life. And I'm just going to take you through some of the key data to just really highlight this. So this is one of our first studies and key pivotal studies to get our CE marking. You can see here we used a wide range of ages, about 50% pediatrics, 50% adults, in a 12-week study that we randomized across 6 centers, looking at the difference between sensor augmented pump therapy, which is shown in this graph in gray, versus the closed loop therapy in the pinky red. You can see this is across the time from midnight to midnight and your millimoles. So we can show a significant improvement in time in range, a drop in HbA1c and mean glucose, and very interestingly, no increased insulin, daily insulin needed. So, you know, with even the same or less insulin, we were able to demonstrate that the right insulin given at the right time achieves control. It's not just necessarily more insulin is required. And where closed loop really comes into its own is overnight. During the day, there's a lot of other factors that are influencing glycemia, meals, bolus timing, stress, activity, the list goes on. But during the night when the person is asleep, the insulin to play, which is delivered from the algorithm, is able to achieve really tight control without a necessarily increased hypoglycemia. So the really increased time in range during the night is really beneficial to parents sleeping, adults with type 1 sleeping to be able to do better with their children, and school during the day and work during the day, has that phenomenal impact on overall well-being and quality of life. Great to be able to offer tighter control with a peace of mind of less hypoglycemia as well. We also can show this in pregnancy. This was a study quite early on in our research, looking at 4 weeks of randomized control with a continuation phase of people trying to get very much tighter time in range, so 3.5 to 7.8 in pregnancy. And you can see here we're able to show 75% time in range in this tighter range versus 60% time in range in sense augmented pump therapy. And again, you can see the significant difference overnight and less difference during the day, where the algorithm is able to take over and continue. We are continuing to do pregnancy studies, and we've actually got a big one that we're hoping to publish shortly. Young children, we've also done a number of studies. This study, the Kids APO2 study, was published in January. I would encourage you to have a look at that paper. Please, you'll see my email at the end if you wish to contact me to get the paper itself, but you can see it's from 1 to 7. They were fairly well controlled individuals, but even during the 16-week crossover design, they had sense augmented pump therapy, the same technical equipment, so G6, the Dana pump, and the CamAPS, but without the closed loop engaged, versus then in closed loop, the CamAPS algorithm took over and delivered insulin. And you can see very quickly, within sort of 1 month, the difference in glycemic control was established and maintained during that time. So we could have a significant change in time in range, HbA1c, and no difference in the time spent below 3.9. Also in older adults, which we've recently published as well. So this was a 60+ study, because often, again, sort of we often don't necessarily, not for any obvious reasons, offer technology to older people, but they may not. We've got a few people who are using CamAPS, and it's the first time they've had a mobile phone in their lives. And often we think, oh, will they manage the technology? Well, they do manage it exceptionally well. And in this age range, again, you can see the increased time in range, especially overnight, with increased HbA1c or decreased HbA1c and time in range. So really showing through all the age ranges, closed loop is beneficial, and CamAPS can do a significant role. The thing I did want to have a discussion about is, and bringing back to Brian's point, is around closed loop and the impact of type 1 diabetes on life. As we all know, it is a significant burden of managing your own diabetes, or for in sort of this research that I'm showing you here, it was around the impact on the family and the child school development. So it is something that we would very much like to not add further burden by adding further technology. If there's CGM and a pump and now we're adding an app, are we adding extra management burden to the family? This is research that shows that, you know, there's a significant improvement both from child's perspective as well as the parents and wider family's perspective around less time worrying about diabetes, less trouble sleeping, more confidence, more impact. And the the AP02 study that was published in January had a significant quality of life thread to it as well. And so we would recommend you have a read of that. There's some really powerful messages from a sort of children's perspective, but also looking at the impact on the family.
Not only 5-minute warning,
thanks, Brian. Not only do we see this impact in children and from their parents, we see it across the ages. And if you'd like to hear Rachel explaining her impact that Neil referred to earlier, please do have a look on CamDiab's YouTube channel. We've got a number of vignettes from different patients, from different age stages, different experiences, expressing how the impact of closed loop and CamAPS is made on their lives, which is really powerful sort of reading. We're not finished our research either. We've got a number of ongoing studies. The CLOUD study is a 4-year study impacting the closed loop therapy on C-peptide preservation and glycemic control from onset between the ages of 10 and 17. So that's ongoing. We have a study, which I love its name, it's called FAST Kids. It is comparing closed loop using FIASP versus NovaRapid in very young children. We've already completed an adult study showing the difference between FIASP and NovaRapid. We are the only closed loop system actually CE marked for ultra rapid insulin. So we always do our research first in the adult population and then repeat it in the children. So this is the repeat in the children. We've got a CLEAR study, which is looking at fully closed loop, which is obviously the next stage of development for all closed loop. We also have the AP Home 4 phase 4 study, which is a bit of a mouthful, which is comparing Lyumjev to Humalog in adults with type 1. And really excitingly, we've also got a number of type 2 studies and the use of closed loop coming up. So before I hand back to Brian, I just wanting to give you our CamDiab customer support numbers. So if you have any questions or would like to get hold of us, there is the email, the generic email and telephone and the website, but also my email address, candice.ward@camdiab.com. So please feel free to contact me and reach out to me to ask any questions about the research, or if you wish to obtain any of our research, we have well over 20 plus publications, both from a glycemic point of view, but also a quality of life point of view, that we would be delighted to reference and signpost you to. So thank you very much. I will now stop sharing my screen and hand you back to Brian.
I'm Karen. I work for Advanced Therapeutics with the insulin pump, and I'm just going to talk you through some of the practicalities of using the Dana-I insulin pump in your centres. So what I'm briefly going to cover is the screens and buttons on the Dana-I pump. I'm going to talk you through the menu tree, the training process that I would go through as an insulin pump trainer, changing the reservoir, and then using the pump to deliver a bolus. And then I'm just going to briefly talk you through the AnyDana app, which is our own app. If you've got those patients that aren't quite ready to go onto hybrid closed loop and they need just a little bit of time to get used to insulin pump therapy, then they can use the AnyDana app to deliver their boluses and set temporary basal rates and things like that. So this is the Dana-I screen. The pump is a really simple pump. It does everything that your other pumps on the market would do, but it's actually in a really intuitive, simple format that all patients could understand. So when looking at your home screen, what the patients would see if they were out of the closed loop is they'd be looking for a flashing B. On the home screen, this would say that the basal is being delivered and active. You've also got what basal rate they would be on for that hour next to the flashing B. And then you've got a percentage, 100%, being all of the basal that is programmed into the pump. With regards to the pump controls, it's very, very simple. There are 4 keys. You've got your plus and minus key, which you increase or decrease values. You've then got this little forward key, which is a triangle key, and that takes you from one menu through to the next menu. And then you've got the OK key, which is to confirm or to save any options that you go through on the pump. So the Dana menu tree, so these are all the options of different menus that you can go into from the main screen. It is a carousel menu, so using the forward key, the patient would go through to whatever option they wanted. There is no back key, so if they miss where they want to be, they go all the way around again to get to their options. It's all laid out in a very simplistic way and quite a logical way, which when I'm training patients, I always sort of talk them through sort of train of thought after they've sort of left the room and got home and have to do something on the pump. If they want to deliver a bolus, mostly boluses cover food, so look for the knife and fork. So we talk about the pump in really sort of simplistic terms so that the patients can get to grips with each of the options on the menu. What I do in my pump training is before the patient comes into the room, we get all of the settings for the pump. We're more than happy to share this with you and send this through so that we are aware of, total daily dose, all those safety ratios that we'll be setting in the pump when we set it up. We also provide sort of a copy for the patients just in case anything ever happens and they need to sort of reprogram a pump. They've got all their original settings there for them. So the way I set the pump up, there's 4 steps to setting up a Dana pump. The first menu that I go into is user options. In user options, we can tailor the pump so that it suits the individual patient. So you can have the pump so every time you press a button, it beeps, or you can switch that off. You can have it where it will play a tune after a bolus, or you can turn that off. So I just have a conversation about what will work for individual patients. You tend to find the adults want no alarms, no beeping. However, parents with little ones do tend to like to have beeps if buttons are pressed, so they know their little ones sort of, manhandling the pump. We also changed the password to personalize it from the default password to keep the pump safe, and so it will pair with external devices with their individual password. We then will go into doctor mode. So the doctor mode on the Dana-I is a hidden menu on the pump. In South Korea, where the pump is manufactured. The consultants make all the decision of these safety parameters. They can have parameters in here where it will block a bolus, where it would play a tune and alarm if they hadn't bolused. So the consultants in South Korea set these up. They tell the patients when they're going to eat, what they're going to eat, and then they never tell them where doctor mode is. So they sort of preset all this on the pump. We expect patients to self-manage their diabetes over here. So we take them through doctor mode and we set the safety parameters for them. This is also where we would set the pump up so that it's suitable to be used as an artificial pancreas ongoing, depending on when they're going to go on to CamAPS. I then go in and we do the bolus settings on the pump. So we've covered user options, we've covered the doctor mode. We would then go in and we would set the bolus settings on the pump. Now, the bolus settings on the Dana eye for carb to insulin ratio and correction factors can be set different every hour over a 24-hour period. So this is great for little ones. So you can really vary those carb to insulin ratios and correction factors for children. For adults, it doesn't necessarily need to be sort of as variable. I have to say on the Dana eye, this part takes about 5 or 10 minutes as you're sort of changing each one of those settings. But once it's done, you know, they won't go in and change a full 24 hours ever again. You can just go in and change your time blocks. Once we've set the carb to insulin ratios, we go through dual extended because you can have that on or off. We activate the calculators. We would recommend that you had both. So there's 2 calculators on the pump. One is for where you would put blood glucose and carbohydrates, and then there's another one which is, I call it a pudding calculator, but it's actually a quick bolus calculator where you would just put in carbohydrates. So you can use this for snacks and things. If they are going to go onto CamAPS, you would need the dual and extended bolus to be on, because that is the way CamAPS delivers insulin. So it does it by doing an extended bolus followed by another extended bolus followed by another one. And then we go onto the pump and we edit the basal rates. So the basal rates can be different every hour of the day if you're using one of the circadian rhythms, or you can do blocks, time blocks on there. Often with centres that I cover, we tend to, if they're new to pumps, we start with a flat basal rate and then tweak that for the week that they are just on standard pump therapy, so that they've got a really robust safety net. So for the 2-hour warm-up for Dexcom, or indeed if anything happens and they break their phone, we set the pump up so that it will revert back to standard pump settings. And this is the safety net to enable them to always have access to insulin. So the more accurate we can get this, especially for those newer patients to pump therapy, the better it is, you know, for that 2-hour warm up and should anything go wrong. I think fundamentally our job is to keep your patients safe. So if we can get the pump settings as accurate as we possibly can, then should anything happen to their phone or anything, they can just go back to pump therapy. They can bolus on the pump and their basal rates will already be pre-programmed into the pump. So once I've set up user options, doctor mode, carb to insulin ratio and correction factors, and their basal settings, I then take them through each of the options on the pump. So I cover history and I talk the patients through if for any reason CamAPS sends you a message saying it's not sure if the bolus has got through to the pump, then they would always check everything into the history. So anything that the pump does is stored in history, from reservoir fills to occlusion alarms through to average daily dose. It all sits in history. So I talk them through what to look for and where they would find the information if they were ever unsure that a bolus had been delivered or the message from the app hadn't got through to the pump. It's a very rare occurrence, but if it does happen, it's always good to check on the pump, because that will store what it's actually delivered. I then take them through bolus, how to deliver a bolus using the bolus calculator on the pump, and also the quick bolus option, just in case they ever need to go back and use the options on the pump. I then get them to suspend a pump if they. So I get them to suspend the pump, and then I get them to take it out of suspense so they can see exactly what they're looking at on the pump screen. I get them to lock the pump and then unlock it. You will be surprised how many people will set a password during the setup and then forget it by the time they go home. So it's kind of, I just make sure that they know how to unlock the pump with their password that we've changed earlier on. I then get them to set a temporary basal rate and then cancel that temporary basal rate should they need to. And then we talk through basal settings, and I make sure that they can change those basal settings. So I more or less hand them my demo pump and say, okay, I need you to deliver a bolus via the pump. I need you to change a carb to insulin ratio by the pump for me. And I need you to change a block of basal settings. So they'll know how to do all three of those to keep them safe by the time I've finished with them during the pump sort of training and things. And then we talk through refill and cannulas before we actually go on and start to refill the pump. So I think the most important thing when anybody's finished their pump training with us is that we've kept them safe and that we can confidently say that should anything happen to their phone, or if they need to come out and follow sort of 6-day rules out of auto mode for any reason, that they can definitely give themselves insulin. So I really do emphasize the bolus calculator and the bolus options on the pump in the main menu. And then we go on to fill in the reservoir. So in the north of England that I cover, I think one of the biggest things is people would say, well, it's a different mechanism to refilling the pump and the cannula than in traditional pumps. So as opposed to a piston rod, which your traditional pumps will have, you will rewind the piston rod before inserting your reservoir. On the Dana pump, you have a linking screw. And it isn't just, to be different. There's a couple of reasons. That's the linking screw there. That Saul designed a linking screw. One is because one of the biggest faults on traditional pumps that goes wrong is piston rod failure, either because the pump's been dropped and it's broken, or because insulin has dripped onto the piston rod and therefore it's seized the piston rod. So that's the first reason that Saul decided that they would develop a linking screw. It won't break. And what we do during the training is say when they are filling their reservoir, they just spin the hat and on the piston rod. If it's a little bit stiff because insulin has got onto it, they just get a dry toothbrush, brush it off, and it's perfectly safe to use on the next reservoir fill. So they reuse their piston rod on each reservoir fill. The second reason is for accuracy. So with traditional piston rods, they are telescopic. Therefore, the less insulin in the cartridge as the telescopic piston rod is delivering insulin. There's variability on delivery, whereas the piston rod actually delivers the same accuracy of insulin, whether there's 300 units in the reservoir or whether there's 30 units in the reservoir. It delivers consistent accuracy of insulin. So all patients are provided with a setup. I'm going to show you this because it's really hard to demonstrate this in any kind of presentation. It kind of has to be seen to be believed. So the patient will get their piston rod and they will insert it into a reservoir like this one. They will then draw up an amount of insulin and they will pop it into the auto setter. Whoops. They will then, sorry, I've not dropped that in. I can't do things backwards, so I apologize for that. There we go. I have to do it this way and then show you. There we go. Here we go. Where's my other reservoir? I don't think I've drawn up enough insulin into that. I think there's only about 20 units in there. Apologies about this. The linking screw in. There we go. Just put some extra insulin in. It then fixes the linking screw where it needs to be, and it measures the amount of insulin that is drawn up. And then once it's fixed the linking screw and measured the exact amount of insulin, it will Bluetooth it over to the pump. The patient will confirm that, and then it will insert the reservoir and attach the tube in and start to prime. So it wasn't the best demonstration, but as opposed to rewinding a piston rod, they pretty much do that on the outside of the pump. Again, I'm going to cover the same thing that Nick did. So we have a choice of 4 cannulas. I would say these soft release micro and the easy release are fantastic for really tiny people. So I've got a lot of children who are on the 4.5 mil easy release. And I've also got quite a lot of children from around 6 or 7 who are on the 5.5 mil. So just that tiny little bit difference really, really works. It also takes out any risk of kinking of the cannula when the system is learning about them. So CamAPS will learn insulin sensitivity and things like that. So we just take that out of the equation when we first set them up on pumps. So what I normally do in the north of England is if they are new to pump, we tend to put them on an insulin pump and leave them for between a week to 10 days, just on standard pump therapy. But we do attach it to the AnyDana app. So the AnyDana app can be used in both Android and Apple, but it just also gets the patient, not only do they start to get familiar with the filling process and inserting cannulas, but they also get used to delivering boluses via their mobile phone. And that's a free app available, as like I said, on Android and Apple. And again, they can do everything that we would have taken them through during their pump training of temporary basals and things like that. They can do all that via the app. The reason I do all the training on the pump, again, is to keep them safe should anything happen to their mobile phone. But they can do boluses, they can even change their basal rates and change their carb to insulin ratios via their app should they wish to. So for that first 10 days, it's a really great extra facility that they've got just to familiarize themselves with pump therapy. So the training and support that I offer, and I believe Nick's going to offer you guys, there are online training videos. We've got our own YouTube channel. I often get the patients to just have a look at the videos before they come and see me so they can see the different aspects of pump therapy. We do face-to-face pump starts. I do a lot of pre-pump starts, especially with families of little ones. Just things like inserting cannulas. It's always good to get parents to insert a cannula so that they get the confidence of inserting them and how they feel. I also then do the pump start for 2 hours, and I often do a follow-up. So I tend to sit with the patients for about 2 weeks, just in case they ever have any questions, if they need any support with things like cannula changes. If they're new to pump, often they'll want me to just do a couple of cannula changes with them, either virtually or face-to-face, just until the confidence has grown that they know what they're doing and things. We do have a 24 hours, 7 days a week tech support line for the pump. And we also do DPD track service for delivery. So the patients will get a text in the morning, giving them an hour delivery slot. And they also have the option, if they want to have the cannulas and consumables delivered to their place of work. We do patient education days, and we participate in JDRF and DTM meetings as well. With regards to you guys as a centre, We're more than happy to provide you with school training. I saw that was a comment earlier on as how we can support you with school training. We do have school training packs available on both the Dana pump, the Dana app, and I have a CamAPS one that was supplied to me for the families in the north of England. So if you need any of those, please just let us know. We're happy to share them with you. We provide demo pumps and samples for centres. And then if you've got any questions about sort of the pump and pump training, please feel free to contact any of us. Nick is looking after Scotland, but we're more than happy to support him working with you guys and doing your pre-pump and pump starts. And this is the YouTube channel we've got. So what we tried to do, as opposed to having a long sort of training video for the Dana pump, we've tried to put bite-sized videos on all aspects. So if your patient got home and thought, oh, I need to change my cannula, but I've forgot what the steps are, there's a 4 or 5 minute video on how to do each of the cannulas. There's a 4-minute video on programming bolus settings and delivering boluses. So we've tried to have bite-sized videos for each tiny little bit of pump training to support those families. And the advantage is they can stop and start as they want to and as they see is fit. I'm going to open the floor to questions now, which is a little bit unusual. I apologise. I was drafted in at the last minute as one of our colleagues isn't well today. But by all means, if you have any questions, I'll have a look on the chat now. Please let me know. Okay.
Thanks very much, Karen. That was excellent. And thank you for stepping into the breach, as you say, last minute. So appreciate that. And yeah, it's always Sod's law that the demo part is the bit that you think, oh no, but actually, I think you highlighted very well why having a different mechanism for the cartridge refill was important. So a couple of questions that have come in. One was from Sheena asking about the capacity to support new starts in Scotland, which Nick has actually answered in the chat, saying they can do that virtual or face-to-face. Another question that's coming from Janet is, can more than one person have the app on their phone? And that'll probably be particularly relevant, obviously, for parents with young kids. Or...
So with regards to the AnyDana app, yes. So each family member could have AnyDana app on their phone. However, the pump will only talk to one app at a time. So if dad had it on his phone and then the little one was going out with mum somewhere else later on, they wouldn't need a different device. It could be on different phones, but they would have to pair it by putting in a pairing key that the pump would generate to pair to that app. With regards to CamAPS, no, it has to just be on one phone.
Okay. And I think it just shows the appetite that you've created, because I think Kirsty from Glasgow is already saying, when can we arrange training for staff and get their hands on it on a Dana pump? And I think because I used to look after Scotland, I think we've had this discussion. By all means, if you contact us through the office, or my emails on there, or Nick's emails, then we'll accommodate you, in the next few weeks if need be. Well, it's Easter next week, so I'm on holiday, thank goodness. But after that, by all means, I'm more than happy. I'm in Wigan, so I just jump on the train to come up to Glasgow. It's quite a nice sort of journey up there. Yeah, it's funny how everybody who's been home working for the last 2 years is desperate to actually travel to places now.
Oh yeah.
To get out of the house. And I think Morai's probably answered the question about the CamAPS. Then obviously parents could use Diasend app on their phone to do a bit of remote following and stuff. So
yeah, at the moment, CamAPS, you will use Diasend app, which is as long as the phone has a SIM card, it uploads to the cloud and parents will follow that way. But we also set CamAPS up so that it will text parents as well. So it can send text whether their child is high or low, or any alerts that come through on the app, so that they're aware.
Yeah, and another question that's coming from Eleanor, since I seem to be the moderator of questions here, but it's around the fact that I think quite a lot of us see using Dana and the CamAPS system within pregnancy. So what's your experience of maybe starting during pregnancy as opposed to preconception?
Yeah, so I'm like the pregnancy queen. I've had loads of pregnant ladies. If anyone has any questions about using it in pregnancy and you want to speak to a healthcare professional, I have the DSN and the consultants in Burnley Hospital. They've had a significant amount of pregnant ladies that we've put onto the system. So what we found is the safety net that I was just talking about of basal rates, where you try and fine tune that. You're never going to get it right with pregnancies. So I've started quite a few people in the first trimester, and we throw everything at them. So we do pump training and CamAPS pretty much in the same day, because of the volume of insulin that they require as they're going through. The system adapts really, really well and very, very quickly. So I put a lady on about 4 weeks ago, Laura, and within 7 days, it had pretty much got to grips with her. So I'd be a real sort of supporter. By all means, reach out to me, and if you'd like to speak to Christine, she runs all the antenatal diabetes clinics over at Burnley, and they're quite pro CamAPS and the Dana pump. I think the first patient we put on, they said all the consultants sat around the DSN report and thought it was broken because they looked amazing within that target range and sort of the tightness that it was achieving very, very quickly.
I'm not sure what happens elsewhere, like South Korea and Burnley, but all these consultants looking at DSN reports, everybody knows it's a daily attendance and all the work. So they must have just been doing that for a novelty value. No, so I think this is something that comes up quite a lot, and this would be true of any company, is we are seeing increasingly issues with either cannula site issues or CGM site integrity. And I just wondered if you had any specific tips that you see from a Dana perspective as to try and reduce the risk of that, or if somebody's having problems.
Oh gosh, now you put me through it. I would always look from my experience dealing with the cannulas we've got. Luckily, we've got 4 choices with 4 different adhesives, different cannula lengths. So first of all, it would be sort of starting on one of them, and seeing what happens. I've found it's hard because we're sort of covering both adults and children here. I've found with children, the barrier creams that are rubbed on, and there's that massage sort of technique of rubbing on the barrier creams, we find that a lot of the little ones get far less sight sort of issues, and whether it is that sort of massaging those barrier creams in, but we found a lot of the little ones that are now on barrier creams are seeming to get a lot less sight issues. Again, I'm a big fan, and I know some centres don't like it, of steel cannulas. The 5.5 one that we use, the rotating one, is one of the finest needles on the market, so it is like a hair. I'm not sure if I've got one here that I can show you. Let me see whether this is the steel one on my cushion here. No, it's a Teflon, that one. It is incredibly fine, like a hair, but again, so it's about tissue damage, isn't it? So the less cannula fails we can get where they're having to reinsert a cannula, the better chance for all those different sites. So I'm a big fan of the steel ones. I know some centres really do prefer the Teflon cannulas to start, but we tend to, in a lot of my centres, start on the steel to give CamAPS a really good chance of learning as quickly as possible, and then we reevaluate after 4 or 5 months. But hopefully they would, there wouldn't be any cannula fails. They're very, very rare in steel.
Yeah, no, I think one of the challenges we have is actually the adhesive issues, and then the sort of more low grade or progressive allergic reactions. And Scott, I think,
I think if you've got the cannula choice, all the adhesive options are different. Yeah. So if they do have any kind of reaction to one, then we can change them to the next one.
And I think Will's made a very good point in the chat function of, and I think this is a discussion we need to have as clinical teams, is strategically, where do we place the Dana pump? So for women who are potentially pre-pregnancy, pre-conception, due a pump renewal or starting pumps, then when we're talking about the CamAPS system, then strategically they may go on the standalone Dana pump. albeit pregnancy might be a year or two further down the line when they would then get access to the full system. But I think the advantage of having this central funding is it allows us to start opening up these conversations and at least thinking about that strategically. And I like the fact that Nick, who obviously is taking a lead in Scotland, has offered in the chat function that the best support would be to give your email address so that we could all contact you if there's any issues. So I'm sure that's a thanks to Nick for that.
I've got, honestly, because my centres were early adapters of the Downer pump and the system, so I've got quite a breadth. And I was saying to my room earlier on, I've had everything from young autistic adults through to babies. I've got an 83-year-old going on a pump next week. I've got policemen, firemen, pregnant ladies. So yeah, if you've got any questions about different types, then please let me know. If you want to speak to healthcare professionals, I can put you in contact with their experience of the system and that.
Yeah, and I think it's worthwhile saying that a few centres in Scotland have been involved in some of the CamAPS APS pregnancy research work. So I think one of the purposes for this meeting is to try and improve our networking in Scotland so that we have a strong network of clinicians within Scotland, but also the links into advanced therapeutics and CamDiab so that we can gain from other people's experience elsewhere as well. So thanks to all the speakers so far, and indeed for keeping to time. There's no other questions in the chat function. So what I might do, if it's okay with you, Karen, is to move on back to Candice.
Absolutely.
And then that might still allow us a wee bit of opportunity at the end to have a more general discussion.
So thank you. Having 10 minutes to talk through key factors in the success of CamAPS. Sure, you've given me a hard job. But I've sort of summarized it into the following sort of 4 points, which I'll go through very briefly. Is first managing expectations. It's a hybrid closed loop system. It's not a fully closed loop system. None of the systems available on the market are, and it doesn't completely take away type 1 diabetes or cause people to go into remission, but it is a significant help to support managing life with type 1 diabetes, and for the user to understand what the role is of the loop versus the role that they play in managing glucose. So the key factor especially in CamAPS is for the user to understand that carbohydrate counting is still required, and that the more accurate they can be, the better. And then also them to be able to announce some pre-meal insulin, ideally 10 to 15 minutes before eating if they're using sort of Nova Rapid or Humalog, or 5 to 10 minutes if they're using Fiasp or Limjev. And that is their role in supporting the system. And they're no longer needing to be correcting glucose or using sort of changing any features on the pump. It's around carbohydrate counting and meal announcement that is their crucial role, and the algorithm is doing the rest. We have significant support and training for both the people using the system as well as for healthcare professionals to allow people to feel confident in using the system. And then the features like Karen was discussing through around the basics of pump therapy. The closed loop is not going to be able to do its sophisticated role if there's a cannula failure. So we often get contact, why isn't the system working? Glucose levels are really high, but when you look at the data, there's been an obvious cannula issue. They haven't then responded and changed the cannula. If insulin isn't getting into the body, it is no algorithm in the world is going to be able to manage glucose levels. So the things around regular site changes and choosing the right cannula is really important. I'm also a great fan of steel cannulas, especially in the younger population. So I completely sort of agree with what Karen was saying. There are 3 systems available on the market at the moment, and what I've just picked out for you in the slides is just highlighting the key differences between the 3 systems that are available. We've already touched on CamAPS being available from 1 year and up, including pregnancy. It is a very sophisticated algorithm, the most sophisticated learning algorithm available, but we've designed it to be very easy to use. It just needs total daily dose and body weight to start, but there are a number of parameters that you can change to support it. The bolusing from the phone is very popular, convenient, discreet for the users. It has a wide personal glucose target that's key to use to match to different people's lives. The activity and sort of correction modules, sort of boost and ease off, are there to be used. The remote monitoring is there, and it is also available to be CE marked, so for rapid or ultra rapid insulin. So it's got a number of key factors that support people get the best success. Excuse me. The key things around the learning algorithm is its adaptivity. So every 5 minutes it's getting glucose, CGM data, which is fed into its learning algorithm, which then optimizes insulin delivery from the pump every 8 to 12 minutes with a feedback loop every hour as well as every day, looking for patterns, looking at how it should augment the sort of potential algorithm choices depending on glucose levels. So it's constantly refining itself and refining its learning. The actual algorithm, it works independently of settings like the pump basal, insulin to carb ratios, and correction factors on the pump. So if those are maybe out of date, for example, in pregnancy, as you were saying, things change very rapidly. If those settings are out of date, it doesn't mean the algorithm's out of date because it calculates it for itself. So it's constantly learning. So by having set nice insulin absorption, regular set changes, it's able to really do its job. The three things that I gave you as key sort of information is the personal glucose target. That's the target you're asking it to aim for. And you can change this target every half an hour if you really wanted to across the day. So you could have a different target 48 times a day, but most people have a target overnight, a target during the day, and a target going into the evening. And you are able to have it as low as 4.4. We generally only go down there for pregnancy, and as high as 11, and anywhere between it. So for people with very sort of, I'm thinking of the toddlers with insulin variability and glucose variability, you may want it slightly higher and others slightly lower, but you're able to also moderate this and use it, raise the personal glucose target a little bit for the first week back at school, for example, or you going on an activity holiday. You may want to ask the algorithm to aim for a smidge higher just because of that new environment. Boost is asking the algorithm to be a little bit more aggressive for times that glucose levels are a little bit higher. Say for insulin resistance issues, so sickness or something, you want it to boost, but the algorithm will then boost for the period of time you've asked it to boost for. But if it thinks it's going to hit target, it actually stops boosting, even if you've asked it to continue boosting. So it reduces the risk of overshooting the mark and causing hypos. Ease off is an activity setting. So if you're more insulin sensitive for planned activity or hot weather or something, you can set ease off in advance to allow the algorithm to help plan for that activity and have less insulin on board. When you turn the app on its side, you're able to see this sort of screen here, which is showing you what the algorithm is doing in blue, what your glucose levels are doing when last you gave a bolus, and carbs, and when you've used boost is always in red and ease off is always in yellow. So you get a lot of data in the palm of your hand. This is what it looks like. So we encourage people to look at this data to help make in those moment decisions, but we also encourage them to look at Diasend for those setting sort of pattern recognition. So this is what maybe a parent might see on the Diasend app on their mobile phone, to be able to see what's happening while their child, for example, is at school. So they're the carbs, the boluses from the algorithm, and the boluses from the calculator and the algorithm. And then for yourselves in clinic, looking at Diasend, this is the day-by-day comparison. Anything in red is when boost is being used, anything in yellow is when ease off's being used, your carbs, your mealtime boluses, and what the algorithm is doing. We provide a lot of clinical reviews and webinars that we've got on the training, as well as we can support you do that with your individual clinics. The online training is available.
2-minute warning, is it okay?
Thank you. So I would encourage you to have a look and have a play. So that's the email, camdiabtraining.com. And when you register, it asks, are you a healthcare professional, a person with diabetes, or a teacher, or education support staff? And so by logging on and doing the training in different sort of subjects, you are able to support yourself from your mobile phone, a tablet, or the computer to be able to really get to know what CamAPS is and how it works. We've already covered starting CamAPS and when to start the pumps. And then we also offer support. So we've got our CamDiab support, we've got the online and virtual training support we offer. There are various resources like child healthcare plans. We've got webinars which focus on using, for example, CamAPS in pregnancy or in young children. We've got all the user manuals, and we also have peer support that's being created by users who use CamAPS. It's separate from us, as all Facebook and social media is. It has those caveats, but it is a great place to find out what people are actually saying about using CamAPS. And there are our numbers again, should you want to give us a bell and have a chat. So I will hand back to the floor for questions.
Yeah, that's brilliant, Candice. Thanks very much. It's been a really informative session all round. So I could maybe ask Karen and Nick to put their cameras back on as well. And we've got 4 minutes. I think Sarah had said we'll automatically get put into our breakout rooms at 2 o'clock. But a few questions that have come in, some of them maybe have been answered via the group themselves. But one of the questions that's come in, is there a minimum weight or total daily dose requirement to run the CamAPS system?
Absolutely. So the minimum weight is 10 kilos. We have started young babies off the CE licensing. So our youngest was 4 months old. And so their body weight is obviously less than 10 kilos, but we just put in 10 kilos. Body weight is really helping the algorithm around postprandial insulin requirements. And so if it's slightly out until they get to 10 kilos, it's fine. The algorithm is learning in any case. Total daily dose is 5. And so often we talk to clinics around using potentially dilute insulin if somebody is newly diagnosed and may go under the 5 limit. We often find that around the under 8, sometimes just the actual pump functionality, the pump delivers insulin really well, but the U100 and one pulse of 0.05 in U100 is often sometimes too much or too little for these very little insulin requirement individuals. And so if people are thinking about using it, especially around newly diagnosed and potentially honeymooning, and that level will drop, we do consider thinking about dilute insulin, and we've got good experience of using dilute insulin across the country, either in a U10 or U5 dilution. But we can discuss that. It's probably a whole different discussion with the pediatric team separately.
So you've actually answered one of the other questions, which was about dilute insulin. And the good news, Morag, because you obviously answered those questions correctly in the chat, is that you've won the case of champagne from Advanced Therapeutics. So the other question that's come in is whether it's got interoperability with smartwatches, because we're well aware that a lot of people use their smartwatches to interrogate their glucose. So is it something you can visualize in a smartwatch?
Absolutely. In future, we are waiting. Dexcom Follow. We are going to be the first external device to link into Dexcom Follow sort of infrastructure, and they are working on that functionality as we speak. We're just waiting for that. But when we are able to link with Dexcom Follow, you will be able to see the trends of glucose on a smartwatch, like you currently are doing on the standalone Dexcom Follow app. So that is coming. We still would encourage people to use DiaSend, because knowing what the algorithm's doing as well as what's happening with glucose is the best way to take that forward.
And I suppose another question, because quite often we say to individuals on technologies, make sure you download your data periodically. So if there is a technical malfunction, how easy is it to interrogate the system so that you could get their up-to-date sort of insulin carb ratios as well as their insulin sensitivity factors? I think that's a question that came in as well.
So the information is streamed from the app directly to DiaSend every 5 to 10 minutes when there's Wi-Fi or mobile data available. And so when you log on from your DiaSend clinic, if the patient is given permission for that information to flow through, you will have the latest up-to-date information. So if they changed the settings 10 minutes ago, you'll be able to see what their current settings are.
Okay, so maybe time for one last question. Sorry, Nick and Karen, this is a CamAPS is dominating this part of the discussion. So just a reminder to update the evaluation form for everybody before they disappear. You've talked, Candice, about the sort of lower insulin requirements, diluting your insulin. Helen's asked the question, I think maybe discussed it previously, about in more insulin resistant states, such as steroid use, organ transplantation. How do you find the algorithms cope with that?
It copes really well. So if somebody has habitual steroid use, so they're taking steroids every day for their lives for whatever reason, the algorithm will accommodate and learn, because it's their normal sort of habit. So I've got a young child with congenital adrenal hyperplasia and is doing steroid replacements. And then when he has to double dose, for example, we use Boost for that period of time just to help the algorithm sort that out. We've got a number of people going through active cancer treatment using steroids. We've got organ transplantation using steroids. So we have a number of people who are using steroids either long-term or short-term, and the algorithm has proved itself very safe and effective.
Okay, that's brilliant. I'm going to stop it there because I'm conscious of time and I'm also scared of Sarah. So I'd just like to thank Nick, Karen and Candice for some excellent talks and overview. And I think that's been very informative for us and helped maybe address some of the key issues at the beginning, such as upskilling staff. It doesn't address the funding issues, but hopefully I've covered some of that. And it doesn't create more DSNs or dietitians, but hopefully we'll get some creative solutions to working with industry partners to help support that as well. So thank you, and thanks to SPK Healthcare for organising the meeting, and Advanced Therapeutics for sponsoring it. I think everybody will get put into breakout rooms now, and I'll be taking a next session for sort of some of the clinical leads at board level to discuss if there are specific areas that we want to target. But I know you guys are happy to go into breakout rooms and ask specific queries as well. So thanks to all involved, and more importantly, thanks to all the healthcare teams that have given up their time to dial into this meeting. Thank you.